Our second speaker is Amani Fawzi on OCT angiography and neovascular AMD. Can we predict the treatment response?
Thank you very much, and thanks to the organizers and the subday for allowing me to share this data with you. I have no relevant financial disclosures. I think when we first got OCT angiography, we were all very excited about the technology, and I think when we face these patients, when we talk about individualized therapy in neovascular AMD, the first question we get is, Doc, how many injections am I going to need? And so the holy grail, and what we all were excited about, is if we look at these angiograms, is it could be possible to extract some feature or some number from these metrics that can tell us this patient, for example, has that many branches and branching points, and perhaps this patient is someone that you need monthly treatment, and this is another patient that looks very different geometrically and mathematically, and this patient is someone you probably could extend, and perhaps you can get to quarterly treatment in those patients, as we've heard in the last session. And so this is sort of the excitement around the technology. In 2015, this paper from the group in Paris kind of embodies that excitement. We felt that we perhaps could base our treatment decisions now on OCT angiography. And these authors were very creative. They had features that looked like this. They could extract these creative features from the lesions, and you could see these excessive branching points, these small capillaries, the peripheral arcades, and all these features were associated with treatment decisions in these eyes. CFAN, again, these highly branching trees. Compare that to this type of feature where there's only large vessels and no branching points, and these are associated with less treatment decisions. So in my clinic, I try to extract these features from the lesions, and sometimes they defied these creative structures, and all I saw was something very ominous. And so we had at the time a very talented fellow from Vienna, and together we worked on this algorithm. So perhaps we could extract mathematical features by using AngioTool, a software available from the NIH, and look at the patients that are in our clinic in the middle of their treatment, individualized treatment, treat and extend regimen, and define the features that are associated with less frequent injections, so less than 6 weekly intervals, or higher intervals, or less treatment intensity. And so we wanted to compare our features, our quantitative features, to the qualitative features that we heard about. And so here's how it works. You take a lesion, you surround it, and then you extract the number of branching points, and you get this litany of sort of quantitative metrics from that lesion. And so we compared the qualitative features, and there were no differences in those who needed a lot of treatments versus those who didn't need a lot of treatments. So no difference in qualitative. And to our surprise and perhaps disappointment, there were no differences in the quantitative metrics. So regardless of the patients who needed a high intensity treatment or a low intensity treatment, those metrics featured equally. So we wanted to borrow from cancer angiogenesis to try to explain our results. So you start out with a healthy eye with normal vasculature, and then you get a predominance of pro-angiogenic features, dilated vessels, a lot of branching points, active angiogenesis. You treat the patient and you balance that pro and anti-angiogenic, and you get something that looks more normal. So it's stabilization, normalization of the vessels. And then if you excessively treat, you kill the blood vessels and you don't deliver chemotherapy, and that's a poor outcome. So perhaps in these eyes, we had reached that balance of normalization between anti and pro-angiogenic, and regardless of the treatment intensity, we were seeing those similar features in highly normalized vessels that were adequately treated. But another thing that we were not looking at was the three-dimensional structure of these CNVs. So with OCT angiography, we take a complex three-dimensional structure and we collapse it into a 2D simplified flat feature, and that perhaps is taking away some of those interesting features and simplifying them. So before we could do the three-dimensional presentation, we had to take care of something very troublesome in OCT angiography, which is the projection artifact. So if you look at the level of the RPE in a healthy eye, you'll see all the vessels projected there because it's highly reflective, and it's a very problematic thing. So we used the software developed by Yali Jia and David Huang, and we were able then to clean up the image, and right below the RPE we could see a level of flow, and then if you look deeper in the CNV, in the PED type 1 CNV, you could see another level of flow. So once you remove that projection artifact, you start to see multi-level flow in these lesions. So perhaps like a double-decker rather than a flat CNV. So we started seeing features such as this flat neovascularization, a single level lesion, and we had double deckers, and we also had triple deckers when you start to look at the data. And we could compare the distance between these flow levels and then extract some metrics. So the demographics were very balanced except for the number of injections and the interval of injection, as we said before. So the high-intensity treatment group had a lot of injections and a shorter interval versus the low-frequency injection, which had the opposite. And then here, when we looked at 3D complexity, we started seeing differences as well. So the high frequency, the high intensity group had a lot more levels of neovascularization, more complex in 3D, more distance between the levels, and very complex features. And the other thing that we found that we did not expect was a lot of hyperreflective foci in these eyes. So perhaps one thing we tried to extract from the histopathologic data from the SST trials and those surgical trials, perhaps these highly leaky CNVs are having a hard time normalizing. They're constantly leaky. They have fibrin on the surface, which forms a scaffold for a second and perhaps a third layer of angiogenesis. And if we project them and render them, we start to see these features. So here's a lesion that's a single decker. What you see in 2D is exactly what you see in 3D. It's very simplified. Then you see the double decker, and you can see that single vessel rising to form that second deck of the CNV. And perhaps the most interesting is the triple deckers, and here you see how complex that lesion is. There's 3 levels of flow at different levels within the PED. You could even see that penetrating blood vessel that formed the first level, and then from there, the complexity increased. So in summary, 3D complexity is a very interesting feature. Perhaps we should be thinking about it because OCT angiography is inherently 3-dimensional, and this complexity could be a marker of lesions that require more frequent and more intense treatment. We're also looking for other quantitative parameters that could be simply applied in clinic, but I think the most important limitation of this study and the thing that we need to do going forward is look at baseline imaging and in a large prospective cohort to see if the baseline features can indeed predict these treatment intensity groups. And I'd like to thank my team and thank you for your attention.